Hello, ladies and gentlemen. My name is Denis Poddubnyy, and together with Professor Hermann from Berlin, we would like to present the next case in the ASAS Online Case Library. This time, we're talking about a 62 years old male patient who presented to interdisciplinary back pain clinic with severe lumbar pain radiating into both legs, which was not improving with conservative treatment. Painkillers, non-steroidal anti-inflammatory drugs, physiotherapy resulted into almost no improvement. The pain has a long history, but the current pain is intense only for the last 4 weeks. The pain has non-inflammatory characteristics, doesn't really improve with exercise, worsens with movement, and is present all day and night long. Quite important for the discussion of this case is that there was in intervention a diagnostic prostate biopsy performed approximately 6 weeks ago, so clearly before the worsening of the back pain. He has no fever, no peripheral manifestations compatible with spondyloarthritis, but he has plaque psoriasis, which is known for many, many years, represented no severe burden and has been treated topically. No family history of spondyloarthritis, and the patient is slightly obese and has diabetes type 2. On physical examination, we realized that the mobility of the lumbar spine is painfully restricted with paravertebral muscle tension, most likely related to the pain. No motor or sensory disturbances, no peripheral arthritis, enthesitis, or dactylitis, and we noticed a couple of small psoriatic plaques compatible with known psoriasis. In the lab, CRP was clearly elevated with slight leukocytosis, as you see. Otherwise, no major abnormalities, and B27, which has also been performed as a part of the diagnostic procedure, was tested as negative. So, and next, we performed and evaluated past imaging with the following results.
Yes, let me show the X-rays first. Here you can see we performed usual X-ray of the lumbar spine, which is usually performed in 2 planes. We have the anterior posterior view and the lateral view. And you see, due to the obesity, image quality is not optimal. There's some blurring of the contours of the bones, or maybe there was some movements during the acquisition of the X-ray. What you can see is so first you focus on the alignment of the spine. So you look if all the vertebral bodies are aligned nicely to one line that you can see here, or that you can approximate here. And then you have a look at the intervertebral discs that are all more or less of the same height. Sometimes the L5S1 disc is a little less of disc height as the others. So that is a physiological variance. So here it's even maybe due to the small scoliotic bending of the spine, not really well visible, that you cannot really look into this segment over here. So what you can see is there are some bony spurs at the lumbar vertebral bodies. They would resemble osteophytes or spondylophytes, as we call them, at the spine. And if you look at the lower thoracic segments and the upper lumbar segments, you see there's even bridging bone formation. And this bridging bone formation would, for instance, occur in Dish syndrome, in so-called Forestier's disease, but it would also happen in ankylosing spondylitis, so radiographic form of axial spondyloarthritis. And also spondylosis deformans sometimes leads to bridging, but only in a low number of segments. So in this situation, it's very important to check the anterior-posterior view of this X-ray, because in this view, first you can see if there's a scoliosis or not. So you see there's no scoliosis, but the patient is lying or slightly oblique on the table. Maybe that was the reason for this decreased view into the L5-S1 disc. And what's very important to look at on the AP view are the sacroiliac joints. So you can see that the sacroiliac joints, they are in fact well depicted without any erosions. The joint contours are clearly seen. Maybe there is some bone formation up here, which would resemble a bone formation of the capsule of the joint. So it's not really an ankylosis. We might have later on an option to look at this again. Okay, patient was subsequently referred to our MRI facility, and you can see that we did a whole spine MRI, and that is a T1 weighted sequence. So you can clearly see that the fluid is dark, also the intervertebral discs, the nucleus pulposus is dark, the fat is bright. So that's the typical characteristics of a T1 weighted image, and you see the lumbar spine where the pain is there. The discs are well preserved. There is some disc herniation down here in the L5-S1 segment. And we will have a look at the T2 as well. And otherwise, here we have the facet joints on the two sides. And so on one side, they look nice, and on the other side, one might be concerned here about the L4, L5 level, because if you compare, the neuroforamen should usually contain a little bit of fat and also the nerve root inside, and here we see the neuroforamen is filled with something else. So that might be our focus that we will concentrate on. If you look on the thoracic segments, you will see also the bony spurs at the anterior edge, but there is also this bright substance over here in the nucleus pulposus, and it's a T1 weighted image, so it can only be fat, or if there would be gadolinium injection, could be also gadolinium, or in certain circumstances also fresh blood would look like this. But I think it's fat in this situation, and we know that connective tissue frequently has a lot of fat inside, so we can assume there's some connective tissue replacing the nucleus pulposus over here. Looking at the T2 weighted scan, we see again this connective tissue here, but let us focus on the lumbar spine. And we see here that there are dark nucleus pulposus, so the fluid content is in fact decreased. We see now also that the annulus fibrosus is extending over the bony border in quite a number of segments, so we would also assume some disc herniations. In some of the segments, we see the spinal canal is rather narrow. We can see that the fibers of the cauda equina, they are pressed together. They are not like spreading out like we would expect it. And looking again at our facet joint here, we could suspect some lesion. And this was again then imaged with a stir sequence, and we have here the coronal stir sequence. And this is really very good that we have it in the coronal slice orientation, because now we also can look very far to the lateral sides. And if we focus on the lumbar spine, we can see that there is some high signal intensity change in the soft tissues outside of the vertebral bodies. The focus of the change is clearly in the facet joint. And we can also see that there are some bone edema in the L5 vertebral body. So this is a pattern of joint destruction, but also extending into the muscles, into the psoas muscle, which we see here, and also into the erector spinous muscle, which we have here. So there is some severe inflammatory process also extending into the pedicles of the vertebral body, which needs to be addressed by further MRI sequences. So what we did, we acquired a range of T2 weighted sequences. So that's a T2 weighted sequence. So if you look at the characteristics, we have the cerebrospinal fluid in a bright signal, and also the fat is bright. So this is typical for T2. And if we go and look for the anatomy in the, make it a bit brighter here. If we look here, we see that there is, that's usually, so that's the area where we expect the fibers of the cauda equina, and they are pressed together. There's something coming from the back, keeping them together. And we see here, that's how a facet joint would look like. That's the L5S1 facet joint on the right side, and here on the left side. And if we go one level up, we see that here we have the facet joint with a lot of fluid in the joint space. So there is some joint effusion in this joint. So it could be an unstable joint, it could move a bit. But if you look carefully, we also see that this fluid comes out of the joint and forms some small fluid collection here inside the spinal canal. And this would be compatible with the ganglion cyst coming out of the facet joint. So this per se could also happen in a osteoarthritis of the facet joint. But if you look further, you see the muscle of the erector spinal. That's the left part, and here you see the right one, and you see there is high signal intensity change in that muscle that is suggestive of muscle edema or inflammatory process. And also, if you look at the bone itself, that's a non-fat set image, so it's difficult to judge if there is a bone edema here or not. But we could already see in our stir sequence that the bony contours are affected here. So in this situation, it's worthwhile injecting contrast. So we did that. We acquired 2 fat-saturated sequences with gadolinium injection. So this is the resulting image. So in the central, that's the central slices, you see there is some inflammation going on, which I will explain in a minute. And I will start with the axial image. So here we can see that there is this joint cleft, but it's also, we have this cystic change, and you see that surrounding it, there is also inflammatory changes. There are inflammatory changes. They are spreading inside the spinal canal, going around the dural sac, and they are going also into the muscles of the erector spinae in a large amount, and also into the psoas muscle, as you can see here. So you really need to appreciate the full extent of the inflammation, which is taking up quite a lot of this region here and going into the spinal canal, which is a very dangerous sign. And if you look at the sagittal images, you can see that the focus of the inflammation is here with the fluid collection, which shows up dark. because there's no gadolinium enhancement here. But if you look at the sagittal, at the mid-sagittal images, you see that the inflammatory process is also inside the spinal canal and is extending up almost the entire lumbar segment of the spinal canal and also going a bit down. So this is really a very alarming sign. And you see that the space for the cauda equina is really small. And we have here these small bone lesions. So there's a lot of inflammatory pattern going on. And consequently, the patient was sent again to the radiology department, this time for biopsy taking. You see, this is the planning CT. We had here our skin marker and had the patient positioned to access the facet joint. And if you see it here, that's the affected facet joint. I will enlarge it a bit, but you can see compared to the other side, to the left side, which is normally, you see the destruction of the bone and the widened joint space. And the same can also be seen in this sagittal reconstruction over here. So that's, in fact, a very destructive pattern. We have this affection of the joint with extension into the spinal canal, with extension into the erector spinous and the psoas muscle, and we even have a spread of the inflammation inside the spinal canal. So this is by no means any rheumatologic manifestation. And I think based on the biopsy, the patient was diagnosed with Staphylococcus aureus infection. And that's then how the patient was treated.
Yeah, this is, I also think, a very, very nice case, a very complex case. And this is a case where clinical information collected at the initial stage guided also our diagnostic procedures. For example, the fact that there was an intervention, this prostate biopsy, that was a very important piece of data indicating that there might be an entry point for an infection, which could be confirmed at the end, that resulted into appropriate imaging application and appropriate treatment. So the patient received appropriate antibiotics, and there was even the rejection of the mostly affected facet joint. But overall, we have also signs of long-standing disease in the spine. How would you grade this chronic condition, Kai? Is it in your view degenerative process like DISH, or do we have also indicators of psoriatic arthritis with axial involvement and the infection came only on the top?
Yeah, I think that's a good question. We have seen these bony spurs at the thoracic spine, and of course these are frequently seen. If you perform chest X-ray, the lateral view frequently also shows these bony spurs. Most of the time, it is DISH, diffuse idiopathic skeletal hyperostosis, or Forestier's disease, and it is known that this condition is connected to some metabolic disorders like obesity, diabetes, alcoholism, but it's not fully understood why so many people get it. And in this particular patient, there were some of the risk factors mentioned in the history. But we know that also in psoriatic arthritis, we have these really large bony outgrowths. We call them parasyndesmophytes. And as a matter of fact, this patient also had psoriasis of the skin. So there was some risk that it's also psoriasis related change. I have to say, looking at the MRI, it is really not clear if it's maybe long-standing, slow progressing psoriatic change, because these fat here in the nucleus pulposus, this connective tissue, we usually see in a patient with long-standing axial spondyloarthritis. That is the MRI sign that is related to ankylosis in later stages. So I think there are some groups that are researching for DISH, and I know that DISH does not only affect the anterior part. So in some instances, also the ankylosis goes through the disc, but I think it's not yet fully analyzed. So there is, in fact, some hints that maybe also psoriatic disease that the patient has, but it's now the acute clinic that makes the problem down in the L4, L5. But thinking about the thoracic spine, I think it's not really straightforward here.
Yeah, exactly. So, and we also saw that the inflammation was only localized in the area where we suspected infection at the end. So that there was no acute need to treat this case also anti-inflammatory, and after surgical and antibiotic treatment, the patient recovered well.
Yes. I think it's a nice case. Thank you, Denis, for bringing it up, and it was really a pleasure looking at the images again and thinking again about the course of this inflammatory pattern.
Thank you very much, Kai, for explaining all the images and findings. I think that was very helpful in terms of differentiation between primary inflammatory and infectious related problems. I hope you all enjoyed the case, so please stay tuned and expect next case very soon. Thank you very much.
See you next time. Bye-bye.